Well, hello, I'm Doug Apple, back with another special interview for you today. And we're talking about the subject of Medicaid. And now, hold on, if that sounds boring, we're going to make it interesting. It's in the headlines a lot these days. It's being bandied about social media. There's some panic going around about Medicaid, especially if you're one who's listening and you might have fear that you're going to lose your Medicaid. Well, what really is going on? What's the story behind the headlines? Also, there's this idea that the states are taking advantage of a loophole and kind of milking the federal government. There are billions of extra federal dollars going out. Well, we're on the phone line with Mike Sharman. He's the legal counsel for Share Healthcare, and he is also studied up and knows about Medicaid. But let's start here. Mike Sharman, I've got you on the phone line. And some people may be wondering, well, what even is Medicaid for? What's it all about? Where did it come from in the first place? I know George Washington didn't invent Medicaid. So, as a country, the United States of America, where does Medicaid fit into this? And what's the future look like? And what's going on up near you in Washington, D.C. right now regarding Medicaid? So take it away.
Well, thank you, Doug. That is a huge controversy right now on what's going on between the Republicans, Democrats in Congress, being the wedge on how to get any of our reconciliation bills through, whether government's going to stop because of this issue. But let's try to make it simple, because the people who argue want to make it relatively complex, and it really isn't terribly complex. America's always been a compassionate nation. We want to help those who are less fortunate. So Medicare and Medicaid were both designed as tools to help the poor. Medicare for the poor elderly, so that they would have health care, and Medicaid for the poor who otherwise aren't elderly but are still poor and need medical care, and then for the poor elderly to put in some of the spaces that Medicare isn't taking care of. So Medicare, Medicaid were both designed to be for the poor. Now, the way it is now, Medicare takes care of everybody who's retired, and you have to have it whether you like it or not. Medicaid is supposed to take care of the poor, but here's some statistics that the New York Times, which is no conservative outlet, that the New York Times had compiled just recently. All births in the United States, 41% of them are paid for by Medicaid. Now, do you think that 41% of people having birth are poor? No. But that's how wide the scope and the range of who's eligible has been. Out of all people and all medical care in the U.S., 21% is paid for by Medicaid. For just adults, 16%. For poor adults, it's 48%. Now, poor, by these statistics, does not mean really what we're thinking of as poor, homeless and all that. No, poor is you can be up to 400% of the poverty line and still be considered poor. So there you go. It's not really poor. Children with disabilities, 59% are taken care of with Medicaid. And I'm surprised it's that low, because it doesn't matter if you're a billionaire. If your child has an IEP in school, has any sort of learning specialty that they have, they are Medicaid eligible. And believe me, every public school makes sure that the child has Medicaid for that, because that pays them. So the point of that little recitation is Medicaid has vastly expanded beyond what it was intended to be. And it is one of the huge drivers of our federal budget and our federal deficit, because it is so large. I mean, when you figure, let's just use that one statistic of 41% of all births in the U.S. are paid for by Medicaid, that lets you see that this is way beyond what it was intended to be. Now, lest anybody think that right now Republicans or anybody else is intending to cut the actual services to Medicaid. That's not the issue. The issue that's right now is, and it ought to be framed this way, no tax on Medicaid providers. Just like Trump is proposing no tax on tips, no tax on Social Security, no tax on overtime. They ought to have the litany, the phrase for this be, no tax on Medicaid providers. Now, why is that? Well, because Medicaid is a partnership between the state and the federal government. The federal government pays basically 50%, is supposed to pay basically 50% of the state's Medicaid expenses. But then they wanted to try to help them out a bit, so they allowed states to tax the insurers, and that tax then is tacked onto what the state's number is for reimbursement. Here's an example that the Epoch Times had done. They say, so there's different reimbursement rates, but 56% is about the reimbursement rate normally. So if a state has a 60% reimbursement rate, spent $10 billion on Medicaid services, the federal government would then reimburse the state $6 billion, right? That's the way it was supposed to be, and that's the way it was set up in 1965 when Medicaid was designed. But then, like all the rest of us, the states look to the tax loopholes to see how they can best benefit their own selves. And so they set up these agreements with hospitals. We're going to tax you X amount. And we're going to agree, we're going to tax you X amount. So if a hospital agrees to pay the state $10 million in taxes, the state then increases the Medicaid payments to that hospital by $20 million. And if the state's reimbursement rate is 60%, it gets $12 million in federal Medicaid spending. So the state receives $22 million, pays $20 million, gets $2 million back in Medicaid costs from the federal government. All right, the total of all of that is over $600 billion of what is costing right now the federal government for this tax loophole that the states have been using. That's what needs to get cut. Like $2/3 of $1 trillion in this inflation of Medicaid that has nothing to do with services to the public.
So are you saying that money coming out of the federal budget is really going towards the profits of the healthcare conglomerates versus going to the patient care?
More is going to the profit of the government conglomerate.
So the state governments.
Right. The states do, part of that does go to the states, say, okay, well, we'll give you more of Medicaid than you otherwise would have gotten. But by the way, we're taking our cut.
Mm-hmm.
And so the federal government pays them back Medicaid expenses, but the state keeps part of that. California has a very large vested interest in all of that right now, of how much they're getting, and that's been one of the big controversies as well. How much is California getting here, and what California has been using their tax loophole amounts, let's say, to pay for their illegal immigrants' medical care, which they otherwise would not have been able to do. And so, in the expenses in California, if we're wanting to make sure that California is not able to use federal dollars to pay for illegal immigrants' health care, then we need to stop that loophole. California has been using that loophole to pay for illegal immigrants' care that they otherwise would not have been able to do, and they're funding it with that surplus of money that we just talked about.
So when you say Medicaid providers, you mean people who are providing medical care to Medicaid patients?
Correct. The doctors in the hospitals, the clinics, etc. They're the ones who get the tax.
Mm-hmm.
And then that tax amount is then put onto the total of the state's cost of Medicaid,
mm-hmm.
sent back to the federal government, and then the federal government sends them that whole amount. The state then splits some of that with the provider, gives them back some of those taxes in Medicaid payments, and then they keep the rest.
Mm-hmm.
So if we just phrase the issue as no tax on Medicaid providers, then that takes care of this loophole, which would then reduce our cost of Medicaid by $600 billion.
So if they close this loophole, is that going to impact the average Joe citizen who is needing Medicaid to pay his bills?
I don't. Well, we'll find out is the answer to that. I don't want to definitively say, oh, no, it won't, because people are always seeking how to make more money, whether it's the state or whether it's a hospital or whether it's an individual doctor.
Mm-hmm.
So they might look to ways to replace this income in other ways. So I don't want to say that a state wouldn't cut their Medicaid payments because of this.
Mm-hmm.
But what I'm saying is it would bring it back to what it was intended to be, take away this accounting machination, and then if something needs adjusting then we can look at that legislatively, rather than try to have a workaround around the workaround.
Sometimes we might say, well, we need Medicaid because the costs are so high. Say, having a baby. You mentioned those stats. Some people might say, well, we have to have Medicaid because it costs so much to go to the hospital and have a baby. Or is there any truth to this? That is why costs are so high, is because of all this government involvement in the healthcare system.
Well, that really is the origin of expense of healthcare. In 1965, when all this was set up, healthcare was a small amount of people's budget. If somebody was truly poor, they had a hard time paying the $10 or $20 to go to the doctor. They had a hard time paying for the hundreds of dollars that it costs for a birth. That was if they were very poor, which is why Medicare and Medicaid was set up to begin with. But normal, working class people, whether they were lower working class, middle working class, upper working class, or rich, had no problem at all paying for either their medical care directly or paying for insurance. It was when these government subsidies and the government requirements started coming in that things started getting expensive. And then when the one big driver of it, you could see from the time of Medicare and Medicaid's implementation, costs started going up because you had a floor. Now, you had a guaranteed amount that was going to be paid for medical care one way or another. That never existed before. Then it also stopped really having local care, because before you'd have a doctor and his receptionist and the nurse in their clinic, and there wasn't a whole lot of paperwork. It was the doctor's notes, the bill that the secretary sent out, the receptionist sent out, and that was that. With the hospital, it wasn't a whole lot more complex than that. Well, now that you have Medicare and all of that, and you have the imposition on top of that of the various requirements that insurers would have, well, now your paperwork requirement got a little bit more. And then when the Health Insurance Privacy and Patient Act, I might have gotten the names wrong, but it's HIPAA is what we all know it by. Patient portability, that was it. Health Insurance Patient Portability Act came in that mandated that the doctors would have all this electronic information, mandated it in certain ways. Then combined, and that was very expensive, both in implementation and in doing it. Doctors estimate that it's between 20 and 30% of all of their care that is just this bureaucratic paperwork cost that they have. You add on top of that the fact that with Medicare came the CPT codes. Those are the codes that every type of procedure a doctor does has to fit within one of these. There's 65,000 of these codes.
Wow.
Right. And so it has to fit within one of those. So you have to have people who know what you're doing. Plus, you can do a procedure that can be coded one way or coded another way. Now, one way might be $100, the next way might be $1,000, and they're almost exactly the same procedure.
Wow.
But they're going to get paid what they coded.
Mm-hmm.
So, of course, there's this gaming going on with that. So you layer on that, and that really raised the rates. So there's just, and that's only we're talking at the federal level. Then you have the state level, which has every state. Remember, Medicaid is a state and federal partnership. You have not just the federal requirements, but then you have the state requirements, which are different. So you have that different type of bureaucratization on there. Then because of all that and all those paperwork requirements, the healthcare providers began to look at economies of scale. Well, we're just one little office. Would it be better if we had 3 offices and just one paper pusher in it? And that would save us money. We could bill the same amount, but it would save money. And then you look at the same thing for hospitals. Well, we're one hospital. What if we have 3? Well, now we've gone way beyond that. You have hospital systems that have 600 hospitals. So you have these oligarchies of healthcare, and then within a geographic area, you might wind up having a monopoly of healthcare. Well, both of those, whether it's an oligarchy of healthcare or a monopoly of healthcare, means they set the price. Mm-hmm. And so, of course, it's going to go up. You mentioned at the beginning that I'm the legal counsel for Share Healthcare. We try as best as we can to cut through all of that and make it as simple as possible again.
Well, tell people what is Share Healthcare.
Right. We're a 501c3 nonprofit, and we're a nonprofit ministry, Christian ministry. So our ministry is to help Christians who are members of Share Healthcare share one another's medically necessary medical expenses. To give you an idea of how simplification winds up meaning less expense, for a family of 4 right now, Share Healthcare's monthly contribution from its members is $349 a month. $349 a month for a family of 4. Now, for an employer-provided health insurance for that same family of 4, its average right now across the nation is $2,600. Well, why is that? Well, because they have to take absolutely everybody. We don't. We take Christians who don't smoke and only drink in moderation. They have to do everything that the federal government and state governments say they have to do. They have to pay for abortions. They have to pay for abortifacients. They have to pay for alcohol abuse treatment. They have to pay for drug abuse treatment. They have to pay, in many states, for the transgender destruction there, that type of what they call health care, which is the opposite of health care. But they have to because they're highly regulated entities. Share Healthcare is not a highly regulated entity. Its healthcare sharing ministries are exemptions from the Affordable Care Act, which was the latest big, huge healthcare bill across the nation. We're not insurance, so we're not regulated by the state's insurance entities. We're just simply a organized way of passing the plate across the nation and across denominations. We do it in an organized way. Like I said, we have set amounts, $149 per month for a single, $249 for a couple, $349 for a family of 4, and then $50 for each child after that. So it's systematic, let's say, and it's organized, and it works. We've been sharing the medical bills. We have no arrearage, let's say. We've been able to, whenever we get the full bill, which has all those CPT codes and all that sort of thing, whenever we get that completed bill, we've been able to share, pay that bill within 30 days of the time we get that regular bill. So it's functional. It works. Why does it work? Well, we have prayer involved. We have people on staff, our member advocates, who that's their job, is to help pray with the people when they are having a medical crisis, when they have a question, and they can pray for anything, too. They can call their member advocate, is that prayer person's title. They can call their member advocate and just say, well, my wife's going for a job interview, my husband's going for a job interview. We'd like to have prayer. It doesn't have to be for medical things. But because we are a group that is founded on biblical principles, because we have people who are praying for the members, because we have members who are praying for themselves and others, our medical costs are just less. That's all there is to that. I mean, you can just see it in practical form. $349 per month for us versus $2,600 for the general population health insurance. That's a huge difference. What's the difference? We're Christians. We're trying to live by biblical values, and we are cutting out the 27,000 middlemen that there are between health care providers and the bill, really. We've cut out all that stuff in the middle, and it just winds up being more effective and less expensive.
Well, if people want to find out more, what do they need to do?
Well, they can look online, sharehealthcare.com, pretty simple, sharehealthcare.com. And since that concept, Share Healthcare, is pretty popular, you'll see there'll be 3 or 4 other healthcare sharing ministries that pay to get bumped ahead of us. We don't. We just have our name, and whoever looks us up, that's where they'll find us, sharehealthcare.com. So just scroll on down until you actually see our site, sharehealthcare.com. Or you can call 1-844-SHARE-HC. 1-844-SHARE-HC. And a real live person talking in American English will answer the phone and answer all your questions. They're very skilled at this.
All right, great. That's Mike Sharman with Share Healthcare. The website again, sharehealthcare.com. Now you know all about Medicaid and what's going on. And for Wave 94, I'm Doug Apple.